Yes. So this, I'll give now just a very brief introduction to the symposium and why we are here and where we are, where we have been, and where we should be going to. So, as you all registered and know, this is the first annual conference that we are planning to do on this area of translational research on the brain, accelerating the pathway from discovery to healthcare. So the overall idea was to bring together people who do very fundamental work and then very gradually shift the presentations to people who do work that's at the interface of bench to bedside, then people who do work at the bedside itself, and then going all the way towards clinical applications and public health policy. So you'll see the transition that I just described during the course of the day. So this is a picture of smallpox, which is a disease that no longer exists. And that's obviously a young boy in Africa with the disease. And in case people think that that only happens in poor, undeveloped countries, here's a picture from New York. So you may be wondering why I'm beginning with this, but there is a logic to this. So smallpox was a disease that entered human populations 10,000 years ago. And it started in Africa and gradually spread through Europe. People said that probably arrived in Europe after Hippocrates because he made very detailed descriptions of all diseases at the time, and nothing like smallpox is mentioned. So it's speculated that it arrived in Europe after Hippocrates. Then it spread through Asia, came to the Americans, and eventually reached Australia. Just to give you an idea, when the disease finally, so if you think that it arrived in the Middle East, Europe after Hippocrates, it ended up arriving in Japan in the 8th century. And when it arrived, it killed 1/3 of the population of the country. And it decimated Native American empires. So it caused about 80 to 90% of death in the Americas. And people always say that history is written by the winners. So I learned history in elementary and middle school in Brazil. And there's a fact that's always said with almost some kind of a pride that Pizarro conquered the Inca Empire of Peru with 152 men and so many horses. I don't know how many horses, but there is a number that you memorize for your tests. But if you think about it, if a country, and smallpox had arrived in Peru just before Pizarro, so 90% of the population had died. So let's say if Australia has 22 million people. If 20 million die of some, terrible pestilence, and then some people who are immune to it just arrive, they probably would have a very time conquering the country. And now our fate is decided by 3 people, so we could have our fate decided by 152 people very easily if we had been completely decimated. So in Australia, smallpox came twice, and it's a very interesting history because it came in 1789 and 1829 and devastated the Aborigines. But then it died out in both occasions and made Australia the only continent without endemic smallpox. And the interesting fact is that there were very successful campaigns in the 19th and 20th centuries, and the World Health Organization certified the eradication of the disease in the world in between 1979 and 1980. And I'll bring more about that. And it's the only disease to have been completely eradicated from the world. So another very brief summary. In the 19th century, the disease killed 400,000 Europeans per year, including 5 reigning monarchs, including Louis XV. And it caused 1/3 of all blindness. And you can see how it happens. People with the pustule in the hand go and scratch the eye, and then they end up blind. And of those infected, 20 to 60% died, but children it was over 80%. But what's most remarkable, I find, is that in the 20th century alone, 300 to 500 million people, so that's just before eradication, so just in the first 7 decades of the past century, 300 to 500 million people died. And in the early 50s, 50 million died in the world per year. And in 1967, which is pretty recent, the WHO reported that 15 million people contracted the disease and 2 million people died in that year alone. And here is a picture that I think is one of the most beautiful pictures in all of medicine that shows here an infected mother, and the baby is put in a hospital in a mother's arms because the baby is inoculated. So the baby is immune and the mother is not. But you can see this is absolutely remarkable. So the history of smallpox vaccination is very interesting. It's always known as the live virus, and the actual smallpox virus was used for vaccination early on in China and Turkey, so in the hope that you would give a very controlled infection. But the virus is live, so the person gets sick, and it's a hope that the disease is not going to be as bad as if you catch it massively, and the person is infectious when they are vaccinated. So the idea came from Ed Jenner, who is the father of immunology here, to that there would be cross-immunization, to use the cowpox virus. So, which eventually now we use the live vaccine virus. So in 14 May 76, which is what this picture displays here, a milkmaid called Sarah Nelms was infected, had the cowpox in her hands. Jenner got the cowpox from her pustules and injected them into James Phipps, the son of his gardener, who then became absolutely immune to smallpox, and was actually, as a young man, he would earn money, like rubbing smallpox material on himself, and he never caught it. So the process of smallpox vaccination started in 14 May 1976. And then in 8 May 1980, Professor Frank Fenner, who is a former director of the John Curtin School, announced to the World Health Organization Assembly that he was the chairman of the Eradication Committee for smallpox, and he announced that smallpox had been eradicated. And then in the official journal of the World Health Organization, the cover was "Smallpox is Dead." But between this and this, it's 184 years, almost to the day. So, so you can see that translation can take a very long time to happen. And it does indeed appear to be the case, particularly in one of the diseases that I'm most focused on, which is depression. And we have witnessed in the last 50 years, maybe 60 years, a very dramatic revolution in neuroscience, which is, in a sense, a failure of translation. So the society, some things are so established now that we cannot conceive that they didn't exist before. So like, let's say in the 40s, there was no such field as neuroscience, and there were people doing, research in physiology, different aspects of the brain. And when actually a small group of people decided to, get together, people think it was strange, or there was nothing common between what one person did and the other, only that they worked in things related to the brain. So the Society of Neuroscience began as a relatively small group in 1969, which is pretty recent. But now it has 40,000 members, and just to give you an idea, the 2009 annual meeting in Chicago had 31,000 attendees. So you can see how a field evolves sometimes by looking at how the most prestigious publishing houses go with their journals in the area. So Trends in Neuroscience from Elsevier was launched in 1978. So Neuron was launched in 1988. Molecular Psychiatry I started in 1996. Nature Neuroscience came in 1998. And yet, no neuroscience discoveries of the last 53 years are used today to help most people who are treated for depression. So the vast, vast majority, over 90% of people who go to a doctor with depression receive medications that have nothing to do with anything that happened in the last 53 years. And those medications are based on what I'm going to tell you in a second. So depression is a disease that was described by Hippocrates 2,500 years ago. So it's not that a new disease that people just realize that it's around very recently. So it's been around for a long time. And actually, the term that Hippocrates used for melancholia, which is black bile, it's still an official name that's used in the American Psychiatric Association Diagnostic and Statistical Manual Classification of Disease for Depression. And it is therefore the only disease that was described by Hippocrates based on his theory of the four humors that still exists as a disease entity today. And it's the second cause of loss of productivity in developed countries. And of course, suicide, which most people are not aware of, is the third cause of death in the 15 to 24 age group. So depression treatment can be done with specialized psychotherapy such as cognitive behavioral therapy or interpersonal, but most people who have clinical depression and go to a doctor end up with medication. And those drugs are drugs that affect monoamine neurotransmitters. So the history that led to those drugs is the following. Julius Axelrod showed that catecholamine neurotransmitters do not stop working after they are released into the synapse. People thought initially, something's released into the synaptic cleft, then it's eventually degraded, and that's the end of it. So he showed that neurotransmitters are recaptured, that there is a reuptake of neurotransmitters by the presynaptic nerve ending, and that reuptake was therefore had to be done by putative reuptake proteins. And so this laid the basis for the idea of which those proteins were later called the transporters. So they transport what's being secreted into the synapses back into the presynaptic neuron. So, so this laid the basis for the monoamine reuptake inhibitors, such as the current antidepressants. So that discovery was made at the NIH, interestingly enough, in the lab where Mali and I worked, because since Axelrod had done his work that gave him the Nobel Prize in 1970, there were people kind of reluctant to remodel or mess with it, so it was very old-fashioned and nobody wanted it. So we ended up there, and in addition, everybody thought that lightning never strikes on the same spot twice, so it's absolutely impossible that people would get the Nobel Prize a second time for work done in the same bench. So, of course, that bench was easily available, and we were able to do some of the work that you'll hear about in the afternoon in that same bench. So, so that work was from 1957. So when people go to a doctor today with depression, they most likely will end up with a monoamine reuptake inhibitor, which is based on the ideas from Axelrod from 1957. And then nothing discovered since 1957, or very little, has made its way to treatment. So there are many barriers for translation in psychiatry. So you can think, it's easy to blame or to find it funny, but you start to look, why is this? Why hasn't translation been more effective in psychiatry? And there are many factors. So, for example, the brain is not accessible. So if you compare it to dermatology, people who work with dermatology, the tumors, the diseases are like right there. You just scrape a little piece and you put in the microscope, and the tissue is immediately available. That's not the case with tissue that's inside a bone formation. Then you cannot extract the disease process and put it into a mouse. So cancer, no matter where it is, could be like in the most inaccessible area. It could be brain cancer, it could be lung cancer. Eventually you do surgery, you get access to the tissue, when the person is alive or when they are dying, and you can put that tissue into an animal, and then the cancer grows, and you can see what kills it or what doesn't kill it, and then you can try it in humans. And of course you cannot extract the psychiatric disease process from a human and put it into a mouse. Then the diseases that we study in psychiatry, they affect higher human functions. And it's because we say that animals don't have those functions that we have the whole kind of rationale for animal experimentation. So we say that animals don't have cognition, they don't have mood, they don't have sophisticated reasoning, etc. So when you have, let's say, schizophrenia, which is a disease of those things that I just said, how could you possibly model it in an animal if the fact that makes you go into animal experimentation is the excuse that the animals don't have those processes which are the object of your study? So in addition, there is the complexity of the brain, and inside the brain you have very rapid, in terms of millisecond interactions of gene function, electrical function, and environmental clues that come through the sensory organs. So how do you even approach that and model that is very challenging. So to address these barriers in translation and why does it take 184 years to go from vaccinating a boy to eradicating the disease in the world, there has been a new discipline called translational medicine that has emerged with a specific focus of bridging that gap from discovery to healthcare and making that much more efficient. In a way, it's kind of a similar process to the basic discipline of pharmacology, that any area of medicine has its own drugs, but there is one central discipline that studies, drug treatment in general, and because of that, drug therapy has greatly improved in the 20th century. So in terms of translational medicine, as a new discipline emerges, it's important to develop specific methods and approaches, which the field has been doing, to develop a workforce that's specialized in the area, and in that regard, we are just starting here a graduate program with the first graduate degree in translational medicine in the Asia-Pacific region, and there are many programs now like that in the United States. You have to engage the community, both the scientific community and the general public. And of course, you have to develop a body of work within your own area. So in terms of translational medicine, there has been a lot of debate on what it is, how is it different from basic science, and where do you put the boundaries between discovery and translation. What I have thought, and I'm writing about this right now, is that rather than create like a dichotomy between discovery and translation, I think it's easier to think of this entire process as one continuum. And I put this continuum as having 6 steps. And so far, translational medicine as a discipline has been broken down into 3 areas that are called T1, T2, and T3, and I'll talk about those. And there is a whole literature around that, and you see these terms very often. So because I thought that the field typically thinks of 3 steps, I think of 6 steps. So one of those steps comes before the T1. So I could either renumber everything, which would create confusion. So in my T2 would be other people's T1. So I thought that to make things easier, I would keep the names as they are, and my T1 would become T0. So that would be the first step, and that T0 process is the fundamental discovery process. So T0 refers to the fundamental process of discovery, which is sometimes forgotten in the discussion of translational science. And I believe very strongly that translation cannot be a pipeline only, or a bridge that would go from nowhere to somewhere, so it has to start someplace. So when you talk about translating something, you have to have something to translate. And I don't believe at all that it's the case that all fundamental discovery has occurred, and if we only bring to the clinic all the advances of recent years, then disease will be conquered. I think that much more fundamental discovery needs to occur so that translation can be effective. And in that context, one could have the best translational pipeline, but without a translatable new fundamental science, such pipeline would become meaningless. And also this step is very critical to differentiate translational medicine as an academic discipline from just commercialization or something that's done like in a drug company. So you go from that step, which is fundamental discovery, to T1, which is described by many scholars, and refers to the step of bringing something from bench to the bedside, to first-in-human studies. So let's say when you saw that Jenner kind of vaccinating that boy and inoculating the boy with the cowpox, that would be T1, first-in-humans. T2 refers to the now classical step of research from bedside to clinical care. Clinical trials for studies are examples in this domain. So let's say after that boy was vaccinated and it worked, then he began to do it in a bigger scale. So that would be T2. So you go from a first-in-human observation to a broader application. So it could be like clinical trials, for example. T3 is a term that has been emerging but requires further definition. So people call T3 anything that's after T2. So policy, guidelines, etc. And I think that it's too broad and it should be cut into 2 areas. So one is making something going from discovery to healthcare policy. So for example, here in Australia, Ian Fraser in Queensland created the papilloma vaccine. So in the United States, in Texas, it became mandatory in the state. So that kind of health policy that made the vaccination mandatory, which was very controversial, but I think it should be reversed. But anyway, that kind of making something which was a new discovery into health policy is T3. But then my point, and that's why I created the separate T4 classification, is that, of course, once something becomes policy, it doesn't mean that it works. So something can be a healthcare guideline or policy and doesn't mean that it's going to work at all. So, for example, hormone replacement therapy was part of healthcare guidelines, and millions of women received it until it was shown recently by a variety of studies, including a study done by Emily Banks, who is here, that she did while she was in the UK, showing that actually hormone replaced therapy increased the risk of breast cancer. And that could only be determined after this had been, healthcare policy or guidelines for many, many decades, actually. So once something is out there and it's widely used, doesn't mean that it's going to be, effective in the long term. And many things that we do today are proven to be wrong tomorrow. So because not all guidelines and policies will work, careful research is needed to determine what works out and what does not, in order to help guide the health care of the future. And then the 6th and last stage is global health. So once something works, then you have to make it available to everybody around the world. And then many of the problems you're going to be dealing with are economical, political, cultural, to make what you are certain to work widely available around the world. So the example that's here, that's why I gave the example of smallpox, because it's the only thing that I can think of that goes from 0 to 5. So there was the initial concept in Jenner's mind. Then he did the first in humans that you saw the painting T1. Then there were larger numbers of trials all over the world. Then a specific vaccine was developed and became health policy in many countries. And, of course, vaccines, some people die, some people, in smallpox, 1 in a million die. But you saw the mortality rate of the disease is very high. So it was shown that the risk was acceptable, and it was clearly demonstrated that it was an acceptable policy. Let's say if the death rate was very high, then I don't think that there would have been massive vaccination campaigns. So after it was clearly demonstrated that it was effective in developed countries, then a concerted global effort led to the final eradication of the disease. So this is the full spectrum of translation. And I think in some diseases, very few, we've gone all the way from T0 to T5, but I think in the area of neurosciences, we are still kind of somewhere in the T0, T1, T2, and we have to make sure that this process is accelerated so that the discoveries that are so abundant in basic science can reach the public. So that's the purpose of this conference, and it's a great pleasure to have all of you here today.